topic is quite an interesting one. In spite of extensive medical experience and the development of new technologies, this condition remains as difficult for physicians as it was first described in 1961 by Dr. Petersdorf and Dr. PSIM. I'm talking about pyrexia of unknown origin. We have an expert amongst us who's going to talk about pyrexia of unknown origin. Dr. Upul Dissanayake, President-elect Ceylon College of Physicians, Sri Lanka, Consultant Physician, National Hospital, Sri Lanka, Trainer for Postgraduate Institute of Medicine, University of Colombo, Teacher for Undergraduate Faculty of Medicine, University of Colombo, former Secretary, Board of Medicine, Postgraduate Institute of Medicine, and member of Presidential Task Force for Dengue. So, sir, please.
Thank you very much. Aibovan, Vanakkam. Good afternoon and Assalamu alaikum. This is the 4 ways of people greeting each other in Sri Lanka. I am from this beautiful lush green country where everybody tries to sort of trudge upstream because, in spite of having difficulties. I'm here on a goodwill visit on behalf of Ceylon College of Physicians, where I happen to be the president-elect. At the outset, let me thank you, the Pakistan Society of Internal Medicine, for the friendship and excellent hospitality. During the next few minutes of my talk, I'll be refreshing your memory on FUO of unknown origin and few interesting cases that I saw at National Hospital of Sri Lanka during last 1 year. In FUO, they define fever first. To weed out the feeling feverish but not having fever, you need to have a temperature of more than 38.3 centigrade or more on more than 2 occasions. When pyrexia of unknown origin was first described in 1961, the duration of fever was set at 3 weeks. People were more tolerant and expected less from doctors. In the era of instant coffees and instant noodles, people having to rush for everything, my patients will not wait for me patiently for 3 weeks for me to tell them that we are in trouble and that they have a condition called FUO. Currently, it is 8 days of fever without a diagnosis after 3 outpatient visits or 3 days in hospital, despite a complete history taking and examination as well as appropriate investigations. The appropriate investigations suggested are routine blood tests, inflammatory markers, autoimmune screen, blood and urine cultures, chest X-ray and abdominal ultrasound. Though there are 4 categories of FUO, I'll be confining myself to the classical FUO, which is what I described at the outset. Here the duration should be more than 8 days. The causes for classical FUO differs from country to country, the region to region, and age and gender. A Sri Lankan study published showed that out of 100 FUOs managed at a tertiary care hospital, 65 had the diagnosis made. Out of the diagnosed patients, 72 were due to infections, and of this, 40% was due to extrapulmonary tuberculosis. Non-infectious inflammatory causes were 20%, and malignancies comprised 7.7%. This contrasts with data from West, where almost 51% had no diagnosis made. Infections comprise 70 to 35, and non-infectious inflammatory causes up to 36, and neoplastic 10 to 20, and miscellaneous 3 to 15. This is a slide to refresh your memory on infectious causes for FUO. The commonest infections that we encounter in Sri Lanka are extrapulmonary tuberculosis, subacute endocarditis, scrub typhus, and melioidosis. Around 20% of FUOs are non-infectious inflammatory disorders. Majority of them are SLE and other vasculitis. Neoplastic diseases are generally due to hematological or solid organ malignancies. And I've seen a couple of cases of FUO due to thyroiditis, pulmonary embolism, and drug fever during the last 1 year of my practice. From now on, I'll rush through a couple of cases I thought interesting. And I run this series of cases in Sri Lanka where I say the mistakes I made in my life. So these will be difficult cases that we've met and sort of we almost went wrong. This is a 26-year-old man who presented to us with dry cough, pleuritic chest pain, mild fever for 2 weeks and constitutional symptoms, and no other systemic symptoms. On examination, he was pale, and the respiratory examination revealed moderate effusion on right side, and all the other systems are normal. His investigations were unremarkable, apart from a low hemoglobin, mild raised ESR, and a CRP. The chest X-ray showed a right-sided pleural effusion, and ultrasound done to aspirate this effusion showed a possible pericardial effusion as well. The transthoracic echo showed the possibility of a pericardial effusion with constrictive pericarditis. Our working diagnosis was now most likely extrapulmonary tuberculosis. There was a possibility of connective tissue disorder, but common things being common, TB was the first DD. The pleural fluid analysis showed a exudate on Light's criteria. However, his ADA was 9, bacterial culture showed no growth, gene expert was negative. Sputum gene expert was negative. However, the Manto was positive at 11 millimeters. With the positive Manto, it was tempting to start on anti-TB drugs. However, in Sri Lanka, ladies and gentlemen, to start on anti-TB treatment is solely the prerogative of respiratory physician. And they were not happy to call it TB because of the lack of microbiological evidence. Next thing is this a connective tissue disorder? ANA was positive at 1 in 80, but no other systems were involved. My patient could not afford complement studies or dsDNA, and neither could the Sri Lankan government, who provides a universal free health care. We were going through the worst economic crisis. Since EULA and ACA 2019 criteria for SLE were not met, we decided to follow up with a repeat chest X-ray and ESR plus or minus a pleural biopsy. The patient went missing from the ward, probably frustrated that we were investigating, but no medication is being given. He presented 6 months later with deep vein thrombosis and a photosensitive rash. We diagnosed him as having SLE and a possible antiphospholipid syndrome. Ladies and gentlemen, when you don't have answers now, the time provides you with answers. This is the case of a 26-year-old medical student who came with prolonged fever for 1 month and constitutional symptoms. Systemic inquiry was unremarkable. She had a past history of mitral prolapse and an undifferentiated connective tissue disorder for which she was on prednisolone and MMF. Her systemic inquiry was unremarkable. Apart from being febrile, her examination findings are normal, and our differential diagnosis at this stage was either subacute endocarditis or a flare of her underlying connective tissue disorder. Her ESR was 90, CRP was 43. Blood, urine and sputum cultures are negative. Her chest X-ray and ultrasound abdomen were normal. Her parents could afford the dsDNA and it was negative. Her C3 and C4 were low. Her transthoracic echocardiogram showed a mass attached to posterior mitral leaflet 10 into 7 millimeter in size. We commenced empirically on IV antibiotics, ceftriaxone and vancomycin. Fever settled within 48 hours, but recurred in 2 days. Her repeated blood cultures are negative, procalcitonin negative, and at this stage, she developed a hemolytic anemia and a subnephrotic proteinuria. We got the echocardiogram repeated by a experienced cardiologist who thought the calcific nodule at the base of the posterior mitral leaflet was like to be a vegetation. And transesophageal echo, it said no TO evidence of infective endocarditis. Her IV antibiotics were omitted. She was diagnosed to have a flare of SLE, started on high dose steroids, clinically improved, and was discharged on prednisolone, MFM, and HCQ. This is a case of a 26-year-old woman who came with fever and erythematous rash over both lower limbs for 2 weeks, constitutional symptoms, unremarkable systemic inquiry, but she had a uncomplicated vaginal delivery 3 months back. The fast history showed that she had a ventricular septal defect and no surgery had been done. On general examination, she had a palpable purpuric rash over bilateral lower limbs and mild pitting ankle edema. Precordial examination showed a pancystic murmur at the left lower sternal edge. Respiratory examination showed few bilateral scattered crepitations, an abdomen, a palpable spleen 2 centimeters below left costal margin. Neurology, including the fundoscopy, were normal. Routine blood tests showed low hemoglobin, low white cell count and platelets, evidence of bicytopenia with possibility of resolving MAHA, and a CRP of 100 and ESR of 148. A UFR showed moderately full of red cells and red cell casts and 2 pluses of albumin. A UPCR was 4.2. A serum creatinine was high, 2.7 milligrams per deciliter. The ultrasound abdomen mild splenomegaly, margin enlarged liver, and bilateral acute renal parenchymal changes. Her chest X-ray showed scattered nodules. The blood cultures done. 1 in 3 showed a group F streptococcus positive, the other one was positive of candida, and the transthoracic echo showed no vegetations. So she underwent HRCT, which showed multiple patchy, fair-defined pulmonary nodules with different densities in bilateral lung fields, predominantly in right. The impression was diffuse pulmonary nodules, which could be due to septic pulmonary emboli, infective endocarditis, or venous granulomatosis. Her ANCA was positive, C ANCA was positive, P ANCA negative. Went ahead with the bone marrow, which was not very informative, renal biopsy, proliferative crescentic glomerulonephritis, likely to be vasculitic in origin. Ladies and gentlemen, tempting to diagnose a rare disease, venous granulomatosis. She underwent a transesophageal echo, which showed patent porine ovale with left-right shunt, small semimembranous ESD, and a linear oscillating vegetation floating in right ventricular outflow tract. The diagnosis was infective endocarditis. So which explained everything exotic in a clinical picture. So instead of doing all this, we could have done a transesophageal echo at the outset, which would have saved a lot of money to the government. So one negative investigation, don't discard the possibility altogether. Case 4, common things are common, however, uncommon things do happen. This is a 58-year-old woman who came with back pain for 2 weeks without red flags, but with significant reduction in mobility. She has past history of diabetes, autoimmune hepatitis, for which she has been on steroid for 6 months. She had traveled to France 2 months back. Subsequently, while at hospital, she developed fever spikes. On examination, there was a spinal tenderness over the mid-thoracic spine, and CRP and ESR were marginally elevated. The MRI showed signal changes and suggestive of tuberculosis. At this stage, her blood culture came as Listeria monocytogenes positive. She was treated with IV meropenem for 2 weeks, but the fever continued. She was initiated on anti-TB drugs pending biopsy. The biopsy said there's granulomatous inflammation with lymphocytes and plasma cells and vague granuloma, mostly in keeping with tuberculosis. But Zeal-Nielsen test was negative for FB. All the other tests were negative for TB, but she responded to anti-TB drugs. The diagnosis was co-infection with Listeria and tuberculosis. The key points, ladies and gentlemen, know your epidemiology. In Sri Lanka, if you get FUO, the chances are that you have got a patient with extrapulmonary tuberculosis. Common things are common, and good history and examinations are paramount, and you don't go with a shopping list of investigations for FUO. And thank you very much.
Thank you very much, sir. Those were very interesting cases. We're going to take questions, just about 2 perhaps from the audience. Yes, sir, please, Professor Zaman. Thank you.
Thank you very much for your excellent presentation. I want to mention very briefly one case I came across recently. One patient came with fever for 2 months, and everything was done normal. T3, T4 and TSH was done on some clinical features. T3, T4 high, TSH suppressed. Somebody started pneumocazole. For 2-3 weeks, no response. Then he went to some other family physician, and he stopped pneumocazole, did a scan, and this case turned out to be subacute thyroiditis decoherence syndrome. So these type of cases do come across in our part of world.
Yes, sir, it's a very interesting observation. I think I have seen about 2 to 3 patients with decoherence in my life coming with FUO. So it's just that you have to look for them and then you find the answer. Yes, thank you very much.
So if there are no more questions, thank you very much, Dr. Upul. Please take your seat. Thank you very much. As we move